So now it is my huge pleasure to invite Yuri Karpenko, head of the Odessa Regional Center of Cardiovascular Surgery, to be my co-host this morning. Yuri, this place is rightfully yours. It's too bad I cannot preside with you together at the same table, well, if you look up the map, Odessa just go straight north and we'll find Moscow. So we're kind of opposite. We have the summer weather already in late May. The pandemic is coming to an end. I'm convinced of that. Fewer and fewer patients, the moods are improving. People are coming to Odessa to spend the holidays. I hope that our webinar will contribute to more optimism in treating, managing patients with severe diseases. And once the diseases are over, once the diseases are treated, people will come to Odessa to recreate. Yeah, just a reminder, Yuri Karpenko is the founding father of our Arrhythmology Association. Back in 2013, we decided that it is time to combine the effort. It's time to unite. And you know, the outcomes of this cooperation was formerly this program, the one that you are looking at during our webinars. 1,300 applications of membership, 1,300 members, a congress that we've made. And in September, we're looking forward to the second session, second congress of EURA, with participation from our colleagues from Minsk, Republican Scientific and Practical Center of Cardiology, Professor Mitkovskaya personally. She put a lot of effort to it. We hope that the meeting will take place in mid-September this year in online format. Please let me announce the scientific part of our agenda, and completing the memory of the first webinar, I would like to give the floor to specifically you, Yuri, as a co-host and as a reporter, to deliver your talk about cardioresynchronization therapy, CRT, once the pandemic is hopefully over. Well, sooner or later, it's bound to be over. So the floor is yours, sir. Thank you very much. Just, well, two questions in the same sentence. Well, when the pandemic is going to end? Well, most likely this year, possibly even this summer. CRT, well, I will try to take this question in my presentation. How we do it together, how it might look like tomorrow. Cardiac resynchronization therapy is indeed super idea, like syncing up two ventricles operation. More than 2 decades ago, Kazo did that for the first time, delivered the first results in patients. So there's no question that CRT is a method of treating people with blockade of the left bundle. More than 10,000 people, patients, randomized CTs with significant improvement of life quality. You see the sinal veins. For 25 years, we've been looking for the Holy Grail, and we seem to have found the perfect solution to this problem. However, up to 30% of people do not respond to CRT. So there must be some other philosophy, some other Holy Grail that we must be gunning for. And I believe it has been found. And let me get there in my talk. The classical indications, it's left bundle blockade, broad QRS, ideal sinus rhythm, but there must be some clinical markers, such as specific functional class of heart failure, also some possibly couple months. Unless there are improvements, well, we go for CRT. The broader the QRS, the better indications are, but they're quite high for the moderately expanded QRS complex. You see the grade 1A indication. If there is AV blockade already, there's no other option. CRT, resynchronizing devices, or a conventional pacemaker. For broader indications, you don't have to wait for the left bundle blockade. It could be just broader QRS, right bundle blockade. However, well, the QRS is supposed to be longer than 150 milliseconds. Okay, what about the dogmas that we know about? Traditional stimulation of right ventricle is bad because it causes asynchrony, and in up to 30%, there is a pacemaker-induced cardiopathy. However, if patients with moderate HF receive the stimulator, their improvement is also far from perfect. High mortality, high hospitalization, readmission rate for heart failure in case of AV blockades, because it's not perfect. This methodology is not perfect. In the past decades, there's been a serious growth of interest, practical interest to direct stimulation of the His bundle and the left His bundle. So, unlike the three-chamber stimulation, it's more physiological because it is improving. It is synchronizing the left ventricle with the right ventricle. It does it simultaneously. Not too many RCTs in that area. However, there have been a number of individual works, articles, collective articles that have shown the benefits of these direct measures. So the benefit of these direct measures. Patients with issues, with cardiac issues, specific ones. So what is a tri-chamber stimulation? This is the chart. You see the lead stimulating the epicardium of the left ventricle. Well, it takes a long time for the pulse to get through the thickness of the myocardium and the Purkinje fibers system to activate it. We see this path, and no matter how hard we try, the 30 non-responders will be there because, like I said, it's not always physiological, and the pulse is supposed to be reaching from this proximal and distal sections. There could be some asynchrony of the pulse movement in the lateral wall of the left ventricle. These are the classical works that show us the activation of the right ventricle, left ventricle in sinus rhythm, 55 milliseconds for the LV, 60 milliseconds total. Right ventricle, you see the blue, the later zones, lateral wall, and the time for the left ventricle activation changes, it doubles. For the stimulation, the LV is improving, but not that much. Total time is still exceeding 100 milliseconds. So no matter what we say, no matter what we like to say, unfortunately, the classical CRT is not biological, although it does help two-thirds of the patients. So we've been walking this path in the dune, this long road in the dunes with the cardiologists when epicardial stimulation didn't help, or we couldn't do it physically. There could be dislocations, there could be high thresholds in the vein. So together with other scientists, we would do the function of the intraventricular septum, and we would implant this electrode to the basis of the papillar muscle. This is the lateral papillar muscle. It's affixing to these walls, and the participation, well, in 30% of patients, this mitral insufficiency goes away because the pulse reaches the lateral valve and the basis of the papillary muscle instantly, much quicker. So the severe mitral insufficiency it goes away. The patients become hyper-responsive. This is the QRS, only 98 milliseconds. This is a not sophisticated surgery. It's also quite safe. So we have walked that path, like I said. This is the appearance several years on. The patient came to us several months ago, and you see how you clearly see the 6 years after the implantation, how the fixation to the septum, how it looks like. Functional class is quite good for the patient. We replaced the device in 2020. Well, there will be some payment for the foreign body anticoagulant therapy, foreign body in the heart. However, patients have atrial fibrillation. Anticoagulants are still already indicated just by virtue of that. So no issues there. This is the biventricular stimulation, one of the patients in 5 years. Right ventricle, we upgraded the 227 milliseconds is the pulse width. So we've reduced the QRS complex by 100 milliseconds. So we're paying a lot of attention to this mechanism, asynchrony, because CRT is not electrical therapy, it's mechanical therapy. So what we get is this kind of synchronicity. Before the surgery, we see asynchronicity. Now we see it improving. Different phases in the septum. So the lateral wall, the width could be up to 300 milliseconds. 300 milliseconds is a mechanic systole of the left ventricle. And you see them strictly aligned here, only 19 milliseconds difference. So we've got a very good mechanical resynchronization. You don't even have to look at the patient's EKG because the main mechanism is right there. It's improving the mechanical geometry of the left ventricle contraction. The GLS was 5.6 and it went up by a single percent, by 1%, just several days on. So that's like what, 20% improvement. So that's in a matter of days. Several months on, it will be even better. So these are the apex of the left ventricle. You see how it's implanted. We've done this with the surgeons already. This patient has been compensated for quite a while. Classical cardiomyopathy with left bundle blockade. So quite a decent functional class. This is the kind of path that we've taken. And well, it was quite tough. It was quite dangerous, and we were very happy to learn about safer and more reliable methodologies of electrophysiological system of the heart stimulation. Vijay Raman, it's a great person that brought back this philosophy to life. We see the left cross of the AV bundle stimulation. This is the true physiological stimulation. When we are stimulating the natural conduction system, and we get a very good synchronicity of the LV and RV. These are very fine. This is a very fine, tricky section in the His bundle. Basically, these are muscle fibers which are protected by fibrous tissue, and there is a very thin section. It's very difficult to pinpoint it and to place the leads. There's no muscles in there, so the thresholds for stimulation are too high. You miss the muscle, the sensing will be poor. So it's a very sophisticated piece of work. The His bundle, the AV bundle stimulation is reaching only as low as 30%, and that's the gurus of this technology I'm talking about, the best of the best. The Purkinje fibers. Well, this is a huge network that we've seen, that we've always known about. Any stimulation in LV with utilization of this conductivity system will be very efficient. How we've done it? We're supposed to focus on these sections of the conductivity system so that the pulse is moving naturally. So these are the basically the sections of the heart conduction system that we believe to be perfect. It's the AV bundle itself, the His bundle itself, and the left cross sterol. Activation of both the septum and this also. You don't have to stimulate the left bundle directly. You have to be close enough with the lead so that the pulse is touching it and kind of pushing the pulse in there. There are visualization, there are imaging technologies that help for every patient, that help determine the anatomy of this heart conduction system. They are showing the perfect sections in the cardiac conduction system where the leads are ideal for placement. So distal stimulation of the left bundle. These are the fibers of the left bundle. Right bundle is in red. It's a very good chart that shows the localization of the cardiac conduction system. This whole thing started several decades ago. Dr. Deshmukh, who treated patients with low ejection fraction, with chronic atrial fibrillation and narrow QRS complex. These were conventional leads. The technical possibility was only in 2/3 of the cases, stimulation of the His bundle. Well, it started 20 years ago. Then they forgot about it for a decade because it was tough. There were no specific tools, particular tools. And once again, I'm bringing you back to the guru of CRT of today, Professor Vijay Raman. Basically, the heart conduction system, well, he's done a lot of work in his center, immense work to spread the word, to disseminate this methodology for the heart conductivity system. So this is clearly the leader in this direction. We've also recalled these small leads, Medtronic leads, very narrow ones for French. No, they were intended for small children. There could have been blockades after open heart surgeries. So these are the special leads that are used. Well, they were originally intended for a different purpose, but they are used to stimulate the His bundle. These are the delivery systems, special delivery systems that are guiding the lead towards the septum and towards where the AV bundle is. So the vendors that come up with this sort of technology, with this sort of medical devices, well, the appearance is pretty much like this. Unfortunately, they're not registered in Russia, but in Ukraine, we've been using these systems, Medtronic systems, for 3 years. We're quite happy. We started using the Biotronic system delivery system because it's more robust per se, and the lead itself, well, it's a conventional 6 French lead. Could have been made by Biotronic, could have been made by Ventril. So these are some good cases that we've collected by now. Biotronic system gives success pretty much every time. This is how it looks schematically. The implantation into the CCS, cardiac conduction system, the implantation of the His bundle. You see my hand and the piece of that valve, I guess, or part of the septum that is sometimes gets out. So it's a very thin lead. It's very difficult to position it. It's very difficult to screw it in. However, well, you just need to practice. I mean, it takes some practice. First 5-7 cases have been tough. However, it was a downhill climb afterwards. It's a routine methodology ever since. So it takes some trying to get to know it. So His bundle HV interval is 55 milliseconds. If we put in the electrode and stimulate the His bundle, we will get an identical EKG in 12 leads. 55 milliseconds, same time before the onset of the peak. So this is the QRS complex is not changed if it's normal. In left bundle blockade, we can overcome it and get QRS aligned. So what if the His bundle is not particularly accurate? Is it good or bad? How do you distinguish them? So this is a non-selective His bundle stimulation without this interval. And this is the right ventricle stimulation. See how these complexes are different? This is a trial in Poland 2 years back. Very nice patterns here. Very even QRS. And there's a plateau on the right-hand side, the right ventricle. And there are some notches below. So in V2 and V4 leads. This is the pulse. This is the pulse coming from the left ventricle to right ventricle. In this case, right ventricle is stimulated, then the left. So this is bad, this is good. And this was proven in a trial when the endpoints of heart failure and hospitalization, death and heart failure hospitalization, they were not statistically significantly different. So if you have Perez stimulation criteria, if you get there, it is a success for those patients. So we have never known that his bundle stimulation can be used to overcome the blockade. This is the higher current because the amplitude is very low, and it's coming through the blockade of the left left cross. So this is the theory of longitudinal dissociation of his bundle. It was proven 100 years ago, Kaufman and Rothenberg, but we didn't give it too much thought. We couldn't clinically use the knowledge that was collected for us 100 years ago. So the higher and higher amplitude current is passing through the left AV bundle blockade. So once again, selective stimulation of his bundle is quite tough, high thresholds, this dislocation. So the scientists have been focusing on stimulating other cardiac conduction system stimulation with smaller defects. And this nice methodology of direct stimulation of the left cross was introduced by the Chinese scientists. It's quite easily done initially. Well, the initial appearance is quite easily done if we control the morphology of this V1 peak. If it's a broader QRS, right ventricle, and then it takes this kind of configuration. RS, and it's becoming quite narrow. The QRS becomes quite narrow. And in some cases, we record the signal, the PV signal. 20 milliseconds, somewhere around that. So this is how it looks. Location-wise, this is his bundle location, 15 millimeters from it, towards the apex is this zone, this area. This is the CT imagery that shows the positioning of the both leads of this electrode. And the LAO X-ray. This is how it looks. This is the positioning. In 2019, this methodology was used for the first time. Left cross of AV bundle stimulation. This is where it is, 178 before the stimulation, and the QRS duration drops down by 50 milliseconds, just like that, by 60 milliseconds. This is how it looks on EKG. This is how it looks on the imagery. This is around with, this is more or less the place where Purkinje fibers are in the left bundle. So this is what it looks like. A right bundle is in blue, the left bundle is in green. His bundle is right there. AV node is in yellow. So rel 15, 30 degrees, it's quite easy to find this. However, you also need to look at the morphology of the QRS complex. We'll get to talk about that a bit later on. So quite significant experience has been generated by some clinics, the Chinese clinics, 632 patients with attempted LBPP. Success rate is nearing 100%. They've been able to penetrate the blockade, mostly patients with AV blockade, and 88 patients with left bundle blockade. So what did it lead us? The stimulation parameters were quite low, I mean, the thresholds were quite high. The stimulation of his bundle, you see the QRS complex is reducing, the blockade is going away, the left bundle is going away. You see the ejection fraction improving. The sinus node is quite strong, it's not getting weaker. hemodynamic parameters, everything is fine. I mean, it's a good way to electrophysiologically stimulate. Quite a big series of patients have been used to demonstrate it. Just one more example of the kind. Left bundle blockade. So this is RAO, LAO, LAO is perpendicular. And this is for the anatomy. This is a his bundle and the left bundle lead that goes into the left cross. Okay, so these are the patterns for those of you who want to look at it. This is prefixation, distended, extended QRS broken up, and then the QR appears, and then ultimately in bipolar pacing we get this kind of QR interval. So this is one of the important criteria. The second criterion is basically the stimulus here, stimulus before the peak of the R. So this activation of the ventricle is supposed to be less than 80 milliseconds. QRS changes in V1 lead, and this is a significant shortening of this interval in V4. We've reached the endocardium of the left ventricle, so this is most likely the perfect place to leave the electrode right there. So these are the criteria that we used. Well, other criteria that are recommended, well, we haven't seen them work according to our experience. Sometimes we even get it wrong. Later on, you program the parameters. In some cases, you need to shorten the latency. In some cases, you need to extend it. So we get the lowest or the narrowest QRS with these settings. So these are the optimal parameters that you need to select by trial and error to get this, to avoid the left AV bundle blockade. So we stimulate the left cross, and we automatically receive the incomplete, sometimes complete blockade of the left cross. This is the EKG that we get as a result. In some cases, an LV lead is supposed to be also added if you're not getting the right QRS. In this case, it will be the left bundle and left ventricle pacemaking. This is a CRT. There is a trial that is combining both technology. So how do we avoid the situation? We stimulate the left ventricle, and it's good. It's going to contract quickly and simultaneously. However, when creating this left bundle blockade, it's not well. It's not cool. We need to correct that. AV delay must be corrected. All bipolar pacing, monopolar, bipolar improves the QRS just like that. And the more sophisticated technology is an additional lead, an additional electrode. Tri-chamber stimulator is required on the right-hand side. Middle part, just the bipolar pacing is sufficient. So these are the two techniques, quite reliable, quite simple ones. This is how it's supposed to look like, very narrow QRS and lack of right bundle blockade. Okay, let's venture forth into this topic. This is the correction of patients with cardiomyopathy, non-ischemic one, left bundle branch pacing. Success was reached in 97% of the cases, 61 out of 63. And we're getting back to these patterns that we're supposed to be looking at. It's V1 lead, and the lessening of this phenomenon to the R peak. It's becoming so much shorter here. And it's better, you don't have to screw the electrode further in, not to perforate the interventricular septum. This is how we started 3 years ago. Of course, we started with the his bundle stimulation. This is the mitral valve. It's a very good biological milestone, very good biological. And we're adding the his bundle blockade as well to make sure that the electrode is easier to get to the implantation site. This is the his stimulation, parahis stimulation is quite good. This wave is okay from the viewpoint of mechanics. Very good mechanics of the contraction of the ventricle. We determine the thresholds. This is follow-up already. QRS is as short as 88 milliseconds if you stimulate the His bundle. And this is the left bundle blockade. It was overcome quite nicely with this technology. This is the second option, the more pragmatic or reliable left bundle branch stimulation. A bird in the tree, a bird in the hands is much better than two in the bush. So basically this mechanic delay is getting reduced. This is how we pass through the septum. This is how geometry changes in V1 lead. And ultimately, V1 we have the high RP, a classical pattern in this patient. Very good QRS, it was induced right after the surgery. This is the first patient, LAO, proximal and distal ends, and this is a rail plane. This is the placement of the lead, subendocardium. And you see the thickness of the septum is quite big in that side of the localization. The pattern is quite nice, however it's just 40%. This is the potential of the left bundle. So you have a quite good QRS here. We are coming back to our measurements here, same patient. OWD was 65 milliseconds, now it's 0. It means that both the septum and the wall they're contracting simultaneously. Zero delay. This is the main thing to get to. When we're talking about proper synchronization. The mechanical delay, in which case we have a very good hemodynamic effect. Some nice X-ray imagery shows the penetration. How deep the electrode penetrates the septum. This is the final depth, about 14 millimeters. Patient is like 6, and this is what we want, 14 millimeters. We see the around 8 millimeters proximal part. The patient is not that thick a septum, 8 millimeters is enough to stimulate the left ventricle. So these are the gold post-op cardiography, EKGs, very good stimulation threshold, 0.5 volts, and you have a very good QRS, like classical patterns, QR in V1 lead and V5. Looks quite nicely. Echo, we are doing this for every patient. We advocate this method. This is the positioning of the electrodes supracardially. The main thing you want to get to, the main goal is this. Contraction of the left ventricle with these parameters. So opposite wall delay, OWD. So that's one of the examples of ours. Inefficient stimulation that we upgraded. We threw in electrodes into the septum and we got a very good stimulation results. 80 milliseconds is okay for patients with a lot of fibrotic changes, fibrotic lesions in the left ventricle. I'm also showing this to my students, to my doctors. This is very clearly seen. Stimulation, non-polar stimulation, and dramatic reduction of the QRS. 154 initially, 115 post-op. The same pattern, same good patterns. This is the yesterday's slides. Completely perfect QRS. This destruction of the heart conduction system in the patient with cardiomyopathy. This aortic valve surgery, history of that. So we didn't change the geometry of left ventricle. but we got the QRS remained more or less the same, around 106 milliseconds, but the STR is now only 53 milliseconds, V1. So if you're looking at that, Yuri, your time is up. Okay, thank you. So what do we ultimately get to? This is the mechanic systole of the left ventricle before and after the resynchronization. And this is the main thing again, this contractility of the left ventricle, how much it gets better. The amplitude of LV contractility is improving so nicely. So these are the surgeries. I guess I might as well scroll down to my conclusions. This kind of therapy is quite efficient in terms of heart failure treatment. The biventricular pacing is improving the endpoints by 2 times. So the final slide with the conclusions, if my time is up, it's up. Now with the stimulation of technologies, with the advent of technologies for stimulating the His bundle, the left branch of the His bundle, constant electrical stimulation for bradycardia and disturbances of intraventricular conduction becomes more and more physiological. And in a certain category of patients, it's perfect. So I was supposed to forget the classical tri-chamber pacing. Well, not really. We're supposed to remember about it. We don't have to disregard it. Thank you very much for your attention.